Okay, now we're going to talk about neurologic meds. We're going to start with anti-epileptics. These are medications for treating seizures. These are not even all the classes of seizure meds. There are a lot of very specialized seizure meds just for a particular type of seizure. That's beyond the scope of what we're doing now. Again, always look at mechanism of action. What does that medication do in the patient's body? We're going to talk about three common classes of anti-epileptics. First of all, Dentoins. Think the one I want you to think about is phenytoin. You may know the trade name Dilantin. They inhibit sodium influx and stabilize cell membrane. They also have some anti-dysrhythmic properties. So what they do is slow nerve transmission. If they stabilize the cell membrane, they slow nerve transmission. That's how they stop seizures from happening. The side effects or adverse effects, they're teratogenic, so that if they're taken in the first trimester of pregnancy, they can cause some birth defects. They can cause gingival hyperplasia. They cause the gums to overgrow, so they can cause some pretty significant dental issues. They can slow the central nervous system. So a lot of people who are taking any med for epilepsy, any seizure med, because it slows nerve transmission, a lot of people complain of feeling foggy or like they can't think well. The Dentoins can also cause thrombocytopenia and leukopenia, so low platelet and white count. They inhibit insulin. So with long-term use, this patient may develop hyperglycemia. So this may lead to hyperglycemia and diabetes. They have a very narrow therapeutic range. So the patient needs regular levels to make sure they're staying within therapeutic range. So interactions for Dentoins, they are highly protein bound. So if your patient who's on Dilantin ends up needing DIG because they go into heart failure, you've got two meds competing for those protein binding sites, right? And that's going to increase the risk of toxicity for both. Sulfonamides and cimetidine may increase levels because they can slow down metabolism in the liver. Calcium antacids and sucralfate, which are they may actually inhibit absorption, so they may lead to low levels. There are some herbs and medications that can lower the seizure threshold. That's not so much an interaction as something you should be aware of with patients who have epilepsy. Barbiturates, rifampin, and ethanol all increase the metabolism of Dentoins so that can lower the levels more quickly, which becomes important when we look at the next class of anti-epileptics, which is barbiturates. So barbiturates can increase the metabolism of Dentoins, so they make them metabolize more quickly. What if the patient is on both of those? That's probably not the best combination, right? Phenobarbital is the most common barbiturate given for seizures. It was one of the earliest seizure medications. They enhance the activity of GABA. GABA is a neurotransmitter that slows everything down. It's an inhibitory neurotransmitter. So barbiturates enhance the activity of GABA. Can you maybe think of any other medicine that might affect GABA? Gabapentin was first used as a seizure medicine. Now it's used a lot for nerve pain because it slows the transmission of those impulses as well. Barbiturates are less teratogenic than Dentoins, so they might actually change a patient over and see if they can stabilize them on barbiturates rather than phenytoin if possible, if they're planning a pregnancy. They're also potentially more sedating. There's addictive and abuse potential. Patients who are taking barbiturates will have withdrawal if it stops suddenly, and that withdrawal usually involves seizures. And again, we have to monitor the therapeutic range. The last class I want to look at is benzodiazepines. These usually end in PAM. These are things like diazepam, lorazepam. They increase the action of GABA. They're a CNS depressant, and they are anxiolytic. So they're used for anxiety and for seizures. They reduce neuron excitability. That means they can be really helpful in status epilepticus. They're also used for muscle spasms and anxiety. Side effects, they may suppress REM sleep. So someone who's taking benzos may sleep a lot more, but they don't get to REM sleep as often. They have some amnesic properties, so some of them more than others. Midazolam in particular is a strong amnesic, but it's not often used for seizures. It's more used for procedure sedation. They can cause oversedation and respiratory depression. Lower doses are recommended in patients with kidney and liver disease. You need to know the reversal agent for benzos is flumazenil. Okay, next category I want to talk about is CNS stimulants. So we've talked about seizures and 3 of the many classes of seizure meds. Now we're going to switch categories and talk about CNS stimulants. So who takes stimulants? Typically, CNS stimulants are prescribed for ADHD or for narcolepsy. These are amphetamine-like drugs. Methylphenidate is a common one. They stimulate the release of epinephrine and dopamine, which increases attention span and cognitive performance and decreases impulsivity and hyperactivity. If we're giving an amphetamine-like drug to someone who has ADHD, it tends to make them less hyperactive, because that hyperactivity is not so much about the activity as the attention span. So if it allows them to focus better, it can decrease that bouncing from one thing to another. Side effects and adverse effects, there's a potential for abuse. They tend to cause restlessness and insomnia, tremors, irritability. They can cause anger. They can cause people to feel angry and frustrated more easily. They can cause tachycardia, hypertension, and palpitations. Anorexia and weight loss. It can be really difficult for kids taking these meds to gain weight as they're growing. Dry mouth, diarrhea, or constipation. So all of the stimulant meds that are amphetamine types, this is the side effect profile we're looking at. Cholinesterase inhibitors, such as neostigmine, they're a cholinergic medication. They suppress cholinesterase, which breaks down acetylcholine, that allows acetylcholine to trigger the muscarinic and nicotinic processes. What that means, it increases muscle tone and myasthenia gravis. These are used primarily in myasthenia gravis to help give enough muscle tone so they can safely swallow, talk, things like that. They also increase GI motility, they slow the heart rate, they can cause bronchial constriction, and they cause increased urination because they cause GI and bladder contractions. Migraine treatments. Migraines are treated with 2 basic types of, well, there are 2 classes we're going to talk about. There are some others, but the most common classes are ergotamines or ergot alkaloids and triptans, and they actually have similar actions and side effects. They're serotonin agonists, so they promote serotonin, and they're vasoconstrictors. So what does that look like? If I vasoconstrict because I've got a migraine caused by increased blood flow to the brain, vasoconstrict is going to help my headache, but I'm going to have higher blood pressure. Now, they can have the opposite effect to cause hypotension. But typically it's hypertension first. They can lead to heart block. They can cause angina and MI. They can cause dysrhythmias, and that's where you may get to hypotension. They can cause cardiac arrest. They can also cause blood clots, stroke by either hemorrhage or embolism or vasoconstriction, and they can cause seizures. So these are not meds to take lightly, but they can be really super helpful for people with migraines. Okay, that's a small section of the things you might see in neuro. The next section will be about GI meds.